PROpel study was an international phase III trial in the first-line setting of men with mCRPC who were randomized to the standard of care of abiraterone acetate with prednisone with ongoing ADT, plus or minus olaparib, a PARP1/2 inhibitor that is FDA approved already for men with homologous repair deficiencies in the post-AR therapy setting. And so this trial was positive, and we updated our results at ESMO this year with updated results showing continued efficacy and delaying progression-free survival above and beyond that active comparator. And the poster that I presented really dived into some of the details of the genomic testing results of all of the PROpel patients. We collected both tumor tissue and plasma cell-free DNA and analyzed those results according to a Foundation Medicine solid biopsy commercial assay, as well as their liquid biopsy assay. And so the PROpel technical abstract reveals some of those results, particularly areas where there's concordance and discordance within patients for the detection of homologous repair mutations like BRCA2 and other DNA repair alterations, but also some areas of discordance and where some of the technical results led to the inability to detect these alterations. So, some of the bottom line results, if you'd like me to describe that, basically show very high level of concordance for most patients, whether if a patient is positive for a BRCA2 mutation, they tend to be positive using both assays, with only a small fraction of patients having false negative results where, for example, the tumor test was positive, but the test was negative in cell-free DNA, and only a small fraction having false positive results where a homologous repair alteration was detected, for example, in cell-free DNA, but was missed on the tumor test. And there's a range of reasons for discordances. Number one is that these things are measuring different alterations sometimes. You can have alterations in plasma that may pick up clonal hematopoiesis, CHIP, which is mutations that are not in the tumor, but rather in leukocytes. And we found a higher prevalence, for example, of ATM and CHEK2 alterations in plasma that were not in the tumor. And I would speculate that some of that might be due to CHIP, which has been well described for HR mutations in prostate cancer before. For genes like BRCA2, where we see really striking benefits of the combination of olaparib and abi, we see very strong concordance, though, with only a small number of false negative results. And false negative results could be due to a low tumor fraction. So when you draw plasma, and if there's not enough tumor DNA present, you will be unable to see a mutation or a deletion, even if it's present, because there's not enough tumor content. And even though PROpel patients in general had a very high degree of tumor content, there are some patients where we would anticipate missing that. And we anticipated that we would only likely miss about 12 patients that had these results, suggesting that the benefits of PROpel were broad, unselected for HRD alterations, and that we probably didn't miss a very large number of cases that would have skewed the results.